Well, good afternoon, everyone. Welcome to our Welch Center Clinical Research Grand Round / Health Equity Jam Session for May, what's today? May the 13th. So I'm Tangela Purnell. I'm one of the core faculty members here at the Welch Center, and I'm also the Associate Director for Education and Training at the Johns Hopkins Center for Health Equity, which are the two primary co-sponsors for today's Grand Rounds lecture. And so we are very excited to have Dr. William Checkley, who, as many of you know, is a very high demand speaker and holds many titles here at Hopkins. So namely, he is an associate professor in the Department of Medicine with joint appointments in the Departments of International Health and Biostatistics. He also is the director of the Global NCD program here, which I'm sure you will hear more about during his talk. And he is the associate director of the Fogarty Global Health Consortium here. And so, again, we are very excited to hear about all of his very exciting and timely work. And today's lecture title will be Strengthening Global Health Research and Training in Low and Middle Income Countries. So welcome, Dr. Checkley, and thank you so much for being here.
No, of course, and thank you very much for inviting me. And today I'm going to share work that comes from our group in the Division of Pulmonary and Critical Care. Throughout the years, we thought that we would consolidate a group of similarly minded faculty members to think about global health issues and bring it under this umbrella of a center that we call the Center for Global Non-Communicable Disease Research and Training. And I wanted to be able to focus today on topics around research from our group, and it's going to be more of a bird's eye view of our work rather than going into the details, and also talk about training and capacity building that our group is focused in low and middle income countries. So here actually you see a picture. This is the picture you see here is a view from a hill close to one of our field sites in Lima, Peru. In Lima, we work in a Peruvian, in a shanty town that's right outside of Lima, about maybe 25 kilometers south of Lima. So this is, you can see kind of the high population density in the area that we work. So as I mentioned, we've over the last years consolidated a group of faculty members and fellows to address issues around global non-communicable diseases. And in particular, our mission is to conduct high quality research and training in the prevention and control of non-communicable diseases in low and middle income countries. And in particular, one of the things that we are very interested in building local capacity with our partners at local institutions and communities where we work. Currently, we are established in Peru and in Uganda and Nepal, and have connections in different, just through collaborations in Guatemala, Rwanda, India, and Bangladesh. As with anything, it does take a village. We are an international working group. The work that we're able to do is in collaboration with our partners, and it involves a variety of institutions, both in the U.S. and outside of the U.S. And this work wouldn't be able to be done without sponsors and funding. Our main source of funding is through the NIH, and in particular, I'd like to give a shout out to the Fogarty International Center, and it's a center, and the individuals there think a lot about capacity building and training, and they're one of the main sources of training grants through the National Institutes of Health for global health issues. We are also funded through NHLBI and the National Institutes of Environmental Sciences, but we've also been lucky to have funding from the Bill and Melinda Gates Foundation, the United Nations Foundation through the Global Alliance for Clean Stoves, and the Medical Research Council, and the consortia that's known as the Global Alliance for Chronic Diseases. So why care about chronic diseases in low and middle income countries? Over the last 10 to 20 years, we've seen a rapid expansion in chronic diseases in LMICs. And here I show kind of graphics from the IHME group comparing disability adjusted life years lost in 1990s and also and then in 2013. And one of the things that you can notice is there's being a rapid expansion of non-communicable diseases throughout the developing world, and it's now currently the major cause of death in LMICs. Chronic disease accounts for about 37 million deaths per year, about 63% of the global deaths. And in particular, if you look at the distribution of deaths, about 80% of those occur in low and middle income countries. And as important, a large proportion of these deaths occur at younger ages in low and middle income countries when you compare it against high income countries. You can see it's about 29% of deaths in less than 60-year-olds in LMICs compared to 13% in high income countries. So here there are, what this tells us that there are many opportunities to be able to intervene and to make a difference. As a group, we have a focus around specific diseases, and as pulmonary and critical care doctors, our big focus has been around COPD and asthma. But more recently, we've also been tackling work around disparities in hypertension and diabetes, sleep disordered breathing, and critical care outcomes. In terms of exposures, air pollution is one of the risk factors that we focus as a group, and not only on household air pollution, but also ambient air pollution. And over the last 10 years, we've also had an opportunity to work in high altitude research and using high altitude as a laboratory to look at the effects of hypoxemia on different health outcomes. And in terms of risk factors, we've had an opportunity to look at a variety of different risk factors, especially those that focus on the health disparities, with urbanization being one of the most important factors that we've focused on. We've also done a good amount of work around traffic-related air pollution, atopy, cigarette smoking, obesity, all of which are growing at a rapid pace in LMICs. And for diagnostics, we've also had an interest in point of care lung ultrasound, and we've had a chance to conduct different studies. Here, kind of this pictorial of lung function gives you also an idea of the range of risk factors that we've been interested throughout the years. In particular, as you know, lung function and lung development begins quite early in life. It begins in utero, somewhere along the lines of 36 weeks, when you get a rapid expansion in alveolar formation that goes through the first couple of years of childhood at a rapid pace. As we've been learning more about chronic diseases like COPD, we've also learned more that many of these diseases actually start in utero, and it is critical that we kind of develop cohorts that start early on in a person's trajectory to understand how we can optimize prevention of chronic respiratory diseases like asthma and COPD. So here, basically showing kind of the timeline all the way from conception to old age, and in the y-axis we have forced expiratory volume at 1 second in liters. This is what you usually expect if you look at the healthy lungs line right here. This is what you usually expect in terms of in terms of lung growth. There's kind of a kind of a rapid growth all the way and up to 25 years of age, and then you get a plateau in you hit a plateau in your lung function, and then it begins to decline as you age. There are several factors that help to understand or explain achieving your full lung growth potential, and then there are other factors that then also helps explain the acceleration of lung function decline with aging. And in particular, we know that tobacco smoking is one of those risk factors that accelerates lung function decline in the adult years. It also has important effects, but we've also learned that it has important effects in utero if you have smoking pregnant women, and that could have an important impact on achieving your growth potential. Household air pollution, in particular from burning of biomass, has become a risk factor of recent interest in the last 15 to 20 years. And there's been a rapid expansion in observational studies and in randomized controlled trials to determine if reductions in household air pollution can play a role in mitigating its effects on lung function. One of the things that I've enjoyed from our work over the last decade is the development of networks and collaborations with different institutions across the world, and the NIH has played a pivotal role in bringing these groups together. In particular, this shows one of the networks that was established by the National Heart, Lung, and Blood Institute and the Fogarty International Center to create centers of excellence in chronic disease research around the world. And we had an opportunity to participate in one of the awards that was given in Peru, and it was a combination of research and training. And that not only allowed us to focus on a variety of research topics in Peru, but also to be able to collaborate with different institutions in bringing our data together and making a bigger case in point for some of the risk factors that we established. I think we've also had an opportunity through the National Institutes of Environmental Health Sciences to join other networks like the Global Environmental and Occupational Hub networks of the GeoHealth hubs. And through this network, we've been able to highlight our work in household air pollution. Now, I can't emphasize enough how important these networks are in terms of being able to expand the work that we do, to be able to identify partners and multi-center trials, to be able to identify different funding opportunities. So it's been a great experience to be part of these international networks. In addition to our work in research, we also have focused on capacity building and training, not only at Johns Hopkins but also in the countries where we work. And throughout the years, among our core group of faculty, we've already had the opportunity to have over 100 trainees, all the way from postdoctoral fellows in the School of Medicine to PhD and master students in the School of Public Health and undergraduates, but also being able to work with students in the School of Nursing, and more recently also with SAIS. The Center for Global Health has played a critical role in providing funds, internal funds, to be able to either establish centers of excellence in multidisciplinary work. So we had an opportunity to have 3 of the university-sponsored global established field multidisciplinary field sites in Peru and Uganda and Nepal, and also to be able to provide opportunities for students to conduct their practicums in our settings. So we've had several of the global health established field placements that the Center for Global Health offers at Hopkins, and more recently we've been able to obtain funding through NIH through 2D43s to sponsor capacity building and research training in both Peru and Uganda, which these grants are ongoing. In terms of the work that we're currently doing, and I decided to just do a quick summary, just give a bird's eye view of the types of research activities that were involved. But in particular, our group is being really interested in household air pollution research. We're currently conducting 2 randomized controlled trials of a clean fuel alternative. We've been using liquefied petroleum gas as a clean energy alternative to be able to reduce household air pollution exposures to safe levels as defined by the World Health Organization, and identify if this and determine if this reduction in household air pollution exposure is associated with health outcomes. In particular, we've been looking at blood pressure, we've been looking at respiratory symptoms and lung function. And in a multi-center trial that involves about 7,200 participants in 4 countries, we've kind of expanded the evaluation of health outcomes to health outcomes across the lifespan, in particular looking at birth weight, severe pneumonia, and stunting in children, and then blood pressure in adults. We've also been able to leverage additional funding to better understand behavior and practices around LPG use, and in particular, being interested in identifying and testing different conservation strategies to maximize the exclusive use of LPG in rural communities in Peru and elsewhere. And quite recently, we also received internal funding from the Alliance for a Healthier World to look at air pollution and silica exposures among brick kiln workers in Nepal. This is a project that we'll be beginning this year. In terms of obstructive lung disease, and when I say obstructive lung disease, the biggest focus is around COPD and asthma. We have several ongoing studies. The first one is that focuses on about 10,500 participants in 3 sites. We've been really interested in developing a simple case-finding tool for COPD in our settings where spirometry is not necessarily available at health centers. And after that, we have also are running a randomized controlled trial focused around a COPD action plan. And the idea is to be able to identify easy and simple to use tools in low and middle income countries like the ones that we're doing the study in Peru, Uganda, and Nepal. And our goal is to be able to provide these tools to local governments to be able to help with better identification of COPD cases and assist in the management of COPD. With Trishul Siddharthan, we've established a site in Uganda, which he leads, and it started through an observational study around urban to rural differences and disparities in COPD outcomes. This was a study of about 2,000 participants, and it also allowed for the establishment of a cohort and the opportunity to ask different questions. Susie Pollard is currently conducting an implementation research trial in Peru. It's about 100 participants, and the RCT focuses around access and adoption of self-management practices in children with asthma. and this is an ongoing it's an ongoing study. She's wrapping it up, and Trishul Siddharthan is working on an intervention trial focusing on low dose theophylline for biomass related COPD, and in particular because we think that the biomass related COPD phenotype is one that has a significant amount of inflammation due to the particulate matter exposures. So he's going to be looking at about 100 participants using a low dose of theophylline, around 250 milligrams of extended release theophylline for 1 year, to see if this leads to improvement in respiratory symptoms and lung function outcomes. In terms of critical care, this is an area that we've also been interested in. We've had an opportunity to establish networks of ICUs in Peru to look at practices in mechanical ventilation and outcomes in mechanically ventilated patients. And more recently, we've joined networks to look at different intervention strategies. I think in arrest pneumonia, we're looking at inhaled corticosteroids and long-acting beta agonists as an intervention to reduce progression to acute respiratory failure. Over the last couple months, due to kind of the rapidly expanding COVID pandemic, we've modified our protocol to include COVID-19 infected patients in the hospital, to see if this is a potential alternative that can help to reduce progression of acute respiratory failure and can have important implications in resource-limited settings where mechanical ventilators are not as available. Similarly, I think based on our observations from our high-altitude research in Peru, Lou Pham and Trishul Siddharthan, both who are just assistant professors in the Division of Pulmonary, are interested in moving in applying positional therapies, and that's basically an upward incline to improve oxygenation in COVID-19 patients and see if it could prevent acute respiratory failure. And more recently, we've also had the opportunity to join a group of researchers in Uganda and Cambodia to help with the rollout of point-of-care ultrasound evaluations in critical settings. Finally, in terms of high-altitude research, this is a particular area of interest to our group and to me. We joined forces with the sleep group at our division with Alan Schwartz and Lou Pham to think about the impacts of hypoxemia, and especially chronic hypoxemia as it is experienced in high altitude settings. And this brought on some interesting observations about the roles of a wedge as an intervention during sleep, with kind of leading to an upward incline and helping to reduce hypoxemia and improve sleep disordered breathing outcomes. So we've had a feasibility trial that we rolled out that we just finished, and we're interested in expanding it to an R1. And quite recently, we received a very good score on an implementation grant to look at the rollout of a multi-component intervention that includes that is driven by community health workers to improve blood pressure outcomes in Puno, Peru. We've for the last 10 years, our primary area of work has been in Peru, but more recently we've had an opportunity to expand to other sites, in particular in Uganda and Nepal, and have close collaborations in Bangladesh. Wanted to give some lessons learned and a summary of some of the studies that we've done. In particular in Peru, as I mentioned, we were part of this network that was established by NHLBI, and this particular grant allowed us to set up a cohort of participants in four different settings. And since kind of the inception of our group in Peru, we've had close to 60 publications that have come out from this cohort. So it's being a very successful collaboration, and more importantly, I think it's led to let us think about other risk factors and other opportunities where we could make a difference in Peru. But in the Chronica study, it was a longitudinal study focused in 3 regions of Peru, in Tumbes and Lima that are at sea level, and Tumbes is in the northern part of the country, and then in Puno, which is at about 3,800 meters above sea level, and it's on the southern part of the country that borders with Bolivia at the Lake Titicaca. And one of the things that I just wanted to share is you can see kind of the diversity of geographical settings, all the way from highly urban settings like Lima, where you have high levels of ambient air pollution, and to rural settings in Tumbes and Puno. And one of the lessons learned from this work is that as we were thinking about where to conduct COPD related research, that places like rural Puno, where you have high prevalence of household air pollution, would be the best place to look at this. And in particular, I think we've been really interested in ambient air pollution, ambient household air pollution profiles across the different settings. And here we're going to just show a summary of information that we collected from about 1,000 households across the 4 different settings. And here in the x-axis, you have basically a minute-to-minute summary of air pollution exposures in 4 different in households in these 4 different settings. And the colors determine the degree of exposure that's seen, where green is what we call kind of the safe levels as defined by the WHO under 25 micrograms per cubic meter of fine particulate matter, all the way to red, which indicates values above 500 micrograms per cubic meter of exposure. And one of the things that we noticed is that in places like Lima, that are highly urbanized, if we're gonna, there is an opportunity to look at kind of range of exposures in the let's say in the medium level of exposures. A significant proportion of individuals spend a good amount of time in this 50 to 100 microgram per cubic meter exposure range in Lima, I think. And so this has given us an opportunity to think about different types of research projects around traffic-related air pollution, and about urban air pollution exposures to explain asthma and COPD outcomes. The work that we did in Chronicas also made us realize that household air pollution is an important problem in Peru, in particular in rural settings, and that it's something that could be intervened upon by finding what's the appropriate type of clean energy alternative that could be used. And in Peru, like in many other settings, liquefied petroleum gas is already used in urban settings, but it has and it's done so in a sustainable manner. Yet when you go to rural settings, this fuel has not yet gotten to a point where it's used in any sustainable way. So we had a chance to test this out in a rural setting of Puno. And here, this is just a picture in the study area of Puno. You can see how separated households can be in the setting. The cardiopulmonary outcomes and household air pollution trial was set up to look at the effects of rolling out a liquefied petroleum gas stove and continuous fuel distribution intervention in 180 participants. And our primary outcomes were blood pressure, respiratory symptoms, and lung function through peak expiratory flow. And we rolled it out in 2 years, and we did we focused in an effectiveness arm, and in an efficacy study, and then we followed by an effectiveness study. So in year one, we had intervention homes that received a free LPG stove and free fuel, which was delivered to their homes biweekly. And we asked control households to continue to use their traditional stoves as they were doing, as a usual cooking practices. But then in year two, we've had the opportunity to then just let intervention households know that to keep their LPG stove, but now they must pay for their fuel, and we're just going to monitor their fuel use. Our hopes was that after a year of LPG use, that we were able to convince them it was a good investment. But then in control households, we said we're going to give them a free stove and then also free fuel. But instead of us going to deliver the fuel at their homes, they would have to just go and pick it up from a local distributor, similar to a subsidy program that is being done by the Ministry of Energy and Mines in Peru. And the reason here is that we wanted to be able to look at barriers other than having to pay for the fuel as reasons as to why people make a decision whether they can use the fuel or not. And in our rural settings, distance from cities and from a distance from distributors can play a big role. You can have households that are maybe 10, 20 minutes from a distributor, as much as like hour to 2 hours away, and many of these houses don't have access to a car, and have to rely on either public transportation or community transportation. So we wanted to see kind of the role of factors other than money in continuous LPG use. A couple of things that we also learned during this process was to be able to do assessment of exposures and looking at compliance. This meant being able to do measurements of household air pollution in individuals by kind of having them wear the devices, and in particulate matter and carbon monoxide and nitrogen dioxide, but also focus on whether they're using the stoves or not. So we were able to install temperature monitors in all the stoves in the home. So in particular, in intervention households, we put a temperature monitor in the LPG stove, and we also had a temperature monitor in the biomass stove, and we did the same for the control households. And here I'm just showing data for the intervention group here, and this involves the entire year of follow-up from like the beginning to the end, and the x-axis is the entire year of follow-up. The y-axis, each of the rows represents one intervention household or participant, and here you can see kind of the different colors of shade that are shaded here. This dark blue means that they were using their LPG stove. Red means that instead of using the LPG stove, they use their biomass stove. And purple means that they were stacking, meaning using both the LPG stove and the biomass stove. And then you have colors for no cooking and missing data. But overall, I think this intervention was very successful at achieving more than 95% compliance with LPG use. And this is reflected by reductions in household air pollution exposures. Here in this graph, I think it got cut off, but the red box plots represent the control group, and the green box plots represent the intervention households. And you can see this is kind of a panel plot where you have particulate matter on the top left, followed by black carbon And then in the bottom panels, you have carbon monoxide and nitrogen dioxide. And it's pretty clear that through any of the, through all these graphs, that the intervention was quite successful in reducing exposures to quite low levels. And in particular, you can see that the majority of households, and these are kitchen exposures, not the personal exposures, but the majority of households were able to reduce exposures to the median exposures to levels that were considered safe by the WHO. And exposures like black carbon were basically eliminated by the intervention. This is another pictorial that helps us to represent data in the similar to the one I showed about in different cities. In the x-axis, you have time in minutes, and in the y-axis, you have the percentage of samples within that minute that fall in kind of the different categories of air pollution exposure. Here, light blue represents exposures below 25 micrograms per cubic meter, and red represents exposures that are above 1,000 micrograms per cubic meter. And you can see kind of these peaks that rise and show when people are cooking. In our settings in Peru, it's usually two cooking sessions per day. And it's clear that at baseline, they look pretty similar, but once the intervention rolls out in months 3 through 12, that you see an important decrease, not only in the means, but also in the peak exposure levels. I'm going to quickly just chat about a couple more studies. We have the Household Air Pollution and Intervention Network trial, which expands the work that we're doing on CHAP. It involves 4 different countries. It's an 18-month randomized controlled field trial of LPG stove and continuous fuel distribution. Involves 3,200 households in 4 countries. And here we're looking at health effects across the lifespan, in particular looking at birth weight, pneumonia, child growth, and adult blood pressure. We had the opportunity to roll out this trial in a variety of settings in the world, and which also represent kind of a diverse collection of geographical variables and economic variables. You go all the way from settings in Chennai, where there's a high population density, to Peru, where we have a low population density. And then we have altitude gradients all the way from in Chennai, where you're at sea level, and then Rwanda and Guatemala that go up in altitude to anywhere from like 1,000 to 2,000 meters above sea level, and then Peru, which is at 4,000 meters above sea level. Briefly, just in the last 10 minutes, I'm going to discuss some additional studies, in particular asthma studies in Peru. We've had the opportunity to conduct a series of observational studies to identify risk factors and potential targets for intervention in Peru. And throughout the years, we've had close to about 4,000 to 5,000 individuals that we followed to study asthma. And a couple of important lessons that we've learned from this is that urbanization in low-income countries is an important risk factor for asthma, and the effects are multifactorial. We've learned that through kind of the let's say urban living exposure, we see higher levels of atopy, higher levels of being overweight, more pollution, more traffic-related pollution, lower levels of vitamin D compared to those living in rural settings, and more allergic inflammation, of course, overall. This also helped us to identify that we need a better definition of urbanization in these for studies, and also identify overweight and obesity as a growing problem in LMICs, and that it's an important attributable risk factor for asthma. We've also noticed, I think, that there's also a lack of medication use for asthma in our settings, and this is underappreciated. So this is kind of, and this helped to identify this as a potential intervention target. And as I mentioned, Susie Pollard is really interested in better understanding the roles of adoption and adherence to the management of asthma outcomes. This is an area that we work in Peru, as I mentioned. That we are in a Peruvian peri-urban community that is south of the center of Lima, this has given us the opportunity to set up close to about 100,000 people that we follow in kind of in two settings, in Pampa de San Juan and Villa El Salvador, and it allows us to do population-based studies. Finally, I just want to talk about the Global Excellence in COPD Outcomes. This is a collaboration with University College London with funding from the UK Medical Research Council. We chose 3 diverse low and middle income country settings in Nepal, Peru, and Uganda to be able to conduct the study. It's a hybrid implementation cost effectiveness trial where we have a case finding component of it. It's about 10,500 participants, and we're looking at questionnaire and using some simple tools to be able to screen for COPD, and to be able to use this as a screening tool to identify those that need to have either further testing and spirometry and get into treatment. And then we went ahead and adapted COPD action plans that are commonly used in high-income countries, and have rolled it out in a group of participants with moderate to severe COPD to look at its effects on respiratory symptoms and quality of life. The study just ended right at kind of the beginning of the COVID-19 pandemic. So and the results should be forthcoming quite soon. And the last thing I'll talk about is our kind of research at high altitude. We currently are working in Puno. As I mentioned, it's about 3,800 meters above sea level. I usually like to show this graph where you have an x-axis, you have the altitude meters, and the y-axis you have barometric pressure on the left and inspired PO2 on the right, and you can see that Puno is quite high up there. It's not uncommon to see individuals in our site in Puno with oxygen saturations at 80%. So they do go around with a significant amount of hypoxemia, both at daytime and at nighttime. And one can see that hypoxemia in itself can be a contributor to low-grade systemic inflammation. Here we are able to look at C-reactive protein values and across our 4 settings in chronicas. In the x-axis, I also put the average SpO2 values that we've seen in these areas, and then just show a box plot of the oxygen saturations. But one thing that is clear, that in a setting in Puno, people that have an SpO2 less than 85% have higher levels of inflammatory markers. So I think hypoxemia in itself is probably playing an important role in chronic disease outcomes at high altitude, and this is an area that we're really interested. In collaboration with Alan Schwartz and Lou Fan, we also started exploring sleep disordered breathing in high altitude. We've had a chance already to work together in publications and grants related to this. And one of the observations that came out of this collaboration was the use of a wedge, and we identified that a 15-degree angle could have an important increase in oxygen saturation during sleep, and that this improvement depended also on the degree of hypoxemia at baseline. So the more hypoxemic you were, the greater the effect was by using this 15-degree angle. We were funded to run a kind of a phased feasibility phase 2 trial on this, which just was completed as well, and And the idea is then now to expand it to a full R1 based on the results of this trial. So a couple of things that we've learned through doing work in global health settings, and I always like to emphasize this. This comes from from one of my mentors who always highlighted the importance of being there and spending time in our field settings to understand the realities. Building collaborations is hard work, but it's also important to acknowledge that it really does take a village to run a project. It's something that is key in many of these low resource settings is to be resourceful and to identify interventions that are low cost and can have a big impact in the communities. And of course, as always, just enjoy the work that you do. I wanted to give thanks to several of our global NCD team members. Obviously, the list is much bigger. This is kind of the group of people who are here at Hopkins. So thank you very much.
Awesome. We are clapping virtually. This is certainly amazing work, and we thank you again so much for sharing many of your key findings and important lessons from this work. I see that we have several questions that have been submitted so far via chat. If you don't mind, I could help to read off some of those questions if you would like to read them in real time. Does that work for you?
Oh, of course, yeah. So let's see.
Okay. So the first question I see is, how did you identify the countries that are part of the NIH network? And we can combine that with the second question: what are the criteria for centers to be part of this network?
Oh, excellent. So this network was selected by the NIH. So there was a competitive process. It was put through a contract rather than a grant. And the way that the settings were selected were based on the groups of people that were brought together, and also just kind of the combined research and training proposals. So as an applicant, we had less of a role in picking the sites. But once the sites were established, here's where we had the opportunity to come together as a group. NIH actually had a great idea in years 3 and 4 and 5 of the grant to come up with supplements that required the collaboration between 2 or more of the research settings. So this brought a lot of brainstorming and also brought several of these teams together to think about potential impacts that they could have across the different countries. So that, I think, was probably one of the biggest benefits of being in the network, and being able to put resources into research ideas is what also brought a lot of these groups together. So I think that's that. I think is a lesson for stakeholders and for funders that even small investments in supplemental funding to these kind of networks can play an important role in bringing people together and in stimulating new research ideas.
Awesome. And we have another question. What major challenges do you encounter in undertaking NCD research in lower middle income countries, especially in Africa?
So I think these are not different for any kind of research. I think the political situations can change quickly, and we've seen this in our settings in Peru and in Nepal. We haven't gone through kind of any difficult political situations in Africa so far, when we've been there for a short amount of time. But I think the political unrest and changes in political situations can play a role. One of the things that one of the challenges that comes up frequently is that you establish collaborations with ministries of health and with just the local governors or local health officials. But one of the things that we noticed in Peru is that these people have fleeting jobs. So you're always in a position of having to have new discussions with have discussions again with new leaders. And so that puts in a challenge, because it's like sometimes you get people say, "Oh, I didn't agree that we're going to do that." So then it's just beginning those discussions again from zero with different people. So that's I think is one of the challenges. Another challenge is always the focus of how is it that you can bring in the issues of the logistics of bringing in supplies and taking out samples. I think so. These are other challenges that come frequently in a place like in Peru. We've learned a lot about what it means to get research supplies into the country, and having to learn all the way from like smuggling to negotiating with customs about kind of the importance of donations for research studies and research trials.
Awesome. So again, the importance of stakeholder engaged approaches and even thinking about the involvement of our key partners.
Mm-hmm.
Awesome. So there was another question. Could you talk more about the 2 COVID-19 therapeutic interventions being tested that you mentioned?
Oh, great. Yes. We joined the network. It's a U.S.-based network to look at combinations of inhaled corticosteroids and long-acting beta agonists in patients with severe pneumonia, including those with COVID. And the basic mechanisms of action are that inhaled corticosteroids help to reduce inflammation and to also improve mucus clearance in the airways, and that long-acting beta agonists help to reduce pulmonary edema. And they haven't been tested kind of in an early stage of pneumonia. We've used these type of drugs in later stages of ARDS, but at that time it actually may already be too late, and much of that hyperinflammation and pulmonary edema that drives to intubation could be potentially prevented if intervened earlier in the stage of the course of the disease. So that's why we're focusing in a group of patients with severe pneumonia, including COVID-19, and trying to prevent the development of acute respiratory failure by giving therapies that help to reduce some of that hyperinflammation, and using inhaled corticosteroids allows you to be more targeted, targeting the organ that matters, the lung, in the sense to reduce that inflammation, and also just by getting more fluid off the lungs to prevent this to prevent the need to have more oxygen or need a mechanical ventilator. So that trial's ongoing, and the one of an upward incline came up from the work that we did in high altitude in Peru, as I mentioned, in collaboration with Alan Schwartz and Lou Pham. We saw that individuals at high altitude who sleep on an incline get improvements in oxygen saturation overnight, and some of these improvements can be quite dramatic. And this happens because of redistribution of the VQ mismatch, maybe also offloading some of the effects of pressure of the lungs on the because of the belly, so because of the abdomen kind of pushing into the lungs. So we are in the process of rolling this out at Hopkins as a potential intervention to see if it improves oxygenation in people with severe pneumonia, including COVID.
Excellent. More questions. What training has been provided to the research centers? And we can combine it with an additional question. How do you work on ensuring capacity building and sustainability of the interventions beyond the study in the research countries?
Great. So I think one of the first things is that we've done in our group is identify individuals in our settings who are interested in chronic disease research, bringing them in as part of the team, being able to give them opportunities through our funded grants to take courses, to join in the research, to be able to also match up and pair with our Hopkins students and I think that has a lot of value uh, for them and for us and for the whole group. I see that Adese Wosu is on, and Adese is a PhD student in the Department of Epidemiology, and she spent now a couple of years in Uganda working together with our other Ugandan researchers, including postdoctoral fellows like Alex Kayongo and Anxious Jackson, and her being on the ground and getting involved in their work also has been instrumental in helping our trainees push the research forward. And it's that kind of like across like U.S. and Uganda collaborations have been very helpful. I think the other thing is, as I said, I think our training grants also help to be able to provide opportunities for training in Uganda or Peru and in the U.S. They can help build that capacity. Your second question was around sustainability. That is a much harder question. We think a good amount about this in our household air pollution work. In both CHAP and HAPIN, we are providing free fuel as an intervention, but we know that this could be a potentially costly intervention it's costly for homes. Then after the studies, it is very likely they may not continue to use it in the same sustainable manner that can provide health benefits. But this is where effectiveness trials like the one that we did in CHAP in year 2 can play a role in identifying or separating those who say, yes, this is worthwhile, it's a worthwhile investment, and I'll move my resources to use LPG fuel versus those who are unable to use LPG in a sustainable manner, and try to identify other potential interventions that can help them to get to continuous and sustainable use. And Kendra Williams from our group has been really interested in these questions and in thinking about like could there be kind of a change in price, or maybe a subsidy, or improve the subsidy that the Ministry of Energy and Mines gives to poorer households to be able to get to that point where LPG is used sustainably. So this is an area that we are definitely thinking about.
And I think that your comment about the sustainability of the fuel is closely tied to an additional question that we have, asking whether you can comment on the potential of biogas and I guess biofuel as an alternative to LPG in rural communities. Have you considered that as a potential strategy?
Yes, I think it's in our settings, the reason why we went with LPG instead of other biofuels, and you can think as biofuels all the way from just ethanol or other types of biofuels. The reason why we went with LPG is that in many countries, LPG already exists as a clean fuel that can be scaled up in rural settings. I think the LPG already comes in. There's already kind of a commercial approach to LPG delivery to homes in tanks that are manageable. So the reason why we went with LPG and because there are already supply chains available. Now the question is, how is it that we expand these supply chains and show that there's a potential for more demand in poor areas of the country? So that's why we went with LPG instead of other biofuels. It's that there's no need to invent new technology or new supply chains. These already exist. How is it that we can expand them to rural settings where we find the household air pollution is the highest in many LMICs?
That makes a lot of sense. Two more questions that I believe are somewhat related. First, is there any reason why you aren't looking at blood pressure in children? And then the second question, does any of this work have application in the US? For example, families in substandard housing in the US without proper ventilation in kitchens, how does air quality compare? So
Yeah.
kids and families.
Great. So kids, it's a great question. If we have anybody who's interested in joining and thinking about blood pressure in children, we have the cohorts and I think opportunities are there. We did one study on blood pressure in kids in relation to vitamin D exposures, but in general, we have not yet expanded our work on blood pressure more widely to children. So this is something that is an opportunity, and we've discussed it in our group as an important area as well.
Awesome. So seeing that we're quickly approaching the 1:15 mark, I now defer to Dr. Apple to see if there were any additional comments or questions that you would like to make.
No, thanks, Will, for chatting with us. I'm looking at your slide here, and I see School of Medicine, School of Nursing, but not School of Public Health. I'm just sort of curious about the structure of your center and.
Oh, so
yeah.
The reason, again, this flyer went to the School of Medicine and School of Nursing to be able to expand our group of applicants.
Yeah.
We never have a problem getting people from the School of Public Health. As a matter of fact, of the trainees that we have, the grand majority come from the School of Public Health. And so these flyers were meant to be able to have a more of an outreach in the School of Nursing and School of Medicine.
Okay.
That's why.
Yeah, and maybe a related question is, I mean, if I understand correctly, your primary is in School of Medicine, and
yes,
I think you're a great example of individual who has transcended sort of domestic medical care to much broader international. So are there any pearls of wisdom for somebody like yourself who has this sort of this population worldview, but based in school medicine?
Oh, well, thank you. And I think one of the things that I'll say is that much of what I've learned comes from my mentors and at Hopkins, and how to be able to think about kind of the topics around global health. I think one of the things that one of my mentors always focused on is as I said at the end, is kind of the importance of being there. There's nothing like spending a year or two or longer in one of the global health settings to get to understand the problems and the realities that are faced in these settings, and what are and just also also getting integrated into the kind of the research culture can help to be in the country, can help to create those collaborations that can make it sustainable and long lasting. So I think that's probably one of the most important lessons that I've learned throughout the years.
Yeah. Right.
Awesome. Well, again, thank you on behalf of both the Welch Center and the Center for Health Equity. Thank you again for the excellent presentation. And thank you all for joining us. So I believe that wraps things up. So
thank you.
All right. Take care. Stay safe.
Bye.
Bye now.